Welcome to this explainer. Today, I'm putting on my residency program director hat because, well, we're building true clinical mastery of the lens. We're moving away from that rote memorization you kind of relied on in med school and stepping toward a deep structural understanding of pathophysiology. If you're prepping for your OCAPs, your written boards, or honestly simply aiming to be an outstanding attending, this is absolutely for you. We aren't just going to memorize facts today. We are going to understand the what, the why, and the how of the lens. Okay, let's dive right in. So let's start with a really staggering fact to anchor why this matters clinically. Cataracts account for exactly 1/2 of all blindness cases worldwide. Just let that sink in for a second. Half. And to put that into perspective, 1/3 of the entire world's population has visual impairment just owing to cataracts. This makes a deep understanding of this anatomy not just some academic exercise, but absolutely critical for your everyday clinical practice. I promise you, you're going to see this pathology every single day of your career. Okay, here's our quick agenda for today. First, the foundation. Second, the surgical translation. Third, nuclear sclerotic cataracts. Fourth, cortical and Morganian cataracts. And finally, number 5, high-yield risk factors. All right, let's jump right into section 1, the foundation, which covers normal anatomy and embryology. So orienting ourselves to this mature lens, anterior is over to the left. I want you to notice the outer capsule right away. This is made entirely of type 4 collagen. Now, just beneath that interior and equatorial capsule is the epithelium. This is a single layer of cuboidal cells, and here is your first absolutely crucial concept. This layer is mitotically active. It gives rise to all new lens fibers for the rest of a patient's life. Finally, notice the zonules attaching right at the equator. Never forget, these originate from the basal lamina of the non-pigmented epithelium of the pars plana and pars plicata of the ciliary body. Looking at this photomicrograph, you can actually see how those continually dividing epithelial cells create literally a lifetime of fibers. The oldest, most densely packed fibers, they get pushed right into the center to make up the nucleus. Meanwhile, the newer fibers form the cortex right beneath the epithelium. Note how the distinction between the cortex and nucleus isn't some sharp, distinct line. It's a gradual, ill-defined transition. It's essentially a biological gradient of age. Okay, time for a quick oculate pearl before we move on. So, in utero, the developing lens is surrounded by this rich blood supply called the tunica vasculosa lentis, right? Well, when that vascular capsule regresses, it leaves behind these clinically insignificant but highly testable remnants. Always make sure to recognize a persistent pupillary membrane or the classic epicapsular star on the anterior capsule. You'll often hear this colloquially called chicken feet. When you see these at the slit lamp, you now know exactly what embryological phase failed to perfectly regress. Moving right along to section 2, the surgical translation, where we'll compare anatomic versus surgical layers. Now, this right here is a classic, common board trap, and honestly a source of massive confusion for residents who are just first scrubbing into cataract surgery. The anatomic cortex you study in your pathology textbooks behaves very differently from the surgical cortex. Anatomically speaking, the cortex is just the newer lens fibers, but surgically, the surgical cortex is a very thin, wispy, and super sticky layer completely adherent to the capsule that gets peeled off like tape at the very end of the case. I really want you to lock in this mental model for the OR. You see, surgeons conceptualize the lens based on how it physically behaves during a case. The nucleus is that firm, opaque center with an amber hue, and it's so hard that you can't just aspirate it. It requires phacoemulsification energy to physically break it apart. Surrounding that is the epinucleus, which is soft enough to be aspirated. And finally, you have that thin surgical cortex we just mentioned, which requires no emulsification energy at all, just vacuum power to strip it away from the capsule. Let's move into section 3, pathophysiology in action, focusing specifically on nuclear sclerotic cataracts. Let's pause here for some active recall. I want you to really think about the physical properties of a hardening nucleus. Imagine you have a 65-year-old presbyopic patient who has needed reading glasses for a decade. Suddenly, they walk into your clinic absolutely thrilled because they can read the newspaper without their glasses. So, why did this happen? Think about what the lens is physically doing to the light. Well, the answer is a fascinating phenomenon called second sight. Remember those mitotically active epithelial cells we talked about? They never stop creating new fibers. Never. And because the lens is trapped inside its capsule, this never-ending creation progressively compresses the central nucleus. It just gets denser and harder. This physical firming actually increases the refractive index of the lens, causing a myopic shift. So the patient's distance vision gets worse, but their near vision temporarily improves. Pretty wild, right? Notice the really striking amber to brown color of this nuclear sclerotic cataract on the slit lamp photograph. While a little yellowing of the lens with age is totally normal, we only call it a pathologic cataract when it actually compromises a patient's vision. Now, listen closely because here is the ultimate board trap. If you take this densely compressed amber NSC and put it under a microscope, the fibers are actually completely indistinguishable from a normal, non-cataractous lens of the exact same age. You literally cannot identify histopathologic changes in an NSC. It is purely a mechanical compression issue. Next up is Section 4, cortical and Morganian cataracts. So unlike nuclear sclerotic cataracts, cortical cataracts actually display highly distinct histopathologic changes under the microscope. This is a true biochemical breakdown. It starts with the complete loss of cell membrane integrity, which then leads to protein oxidation and precipitation. This completely destroys the normal intralenticular osmotic gradients. And the result of that? The lens swells with water. Remember this distinction. NSC is all about compression. Cortical is all about osmotic swelling. Do not confuse the two. Take a look at this biological progression clinically. On the left, using retroillumination, you can see early osmotic damage popping up as these little water blisters or subcapsular vacuoles. Then, as the membrane disruption continues, these vacuoles progress, tracking along the lens fibers to form the classic radiocortical spoking you see over on the right. When your patients complain of severe glare from oncoming headlights at night, this spoking, which is scattering the light, is exactly why. Okay, an absolute OCAP must-know is the Morganian cataract. This is exactly what happens when a cortical cataract goes untreated and becomes hypermature. The swollen cortex just completely liquefies. Eventually, the capsule actually starts to leak this water out into the eye. And without the supportive cortex there to hold it up, the heavy, solid nucleus literally sinks straight down to the bottom of the capsular bag. Clinically, if an elderly patient presents with profound vision loss, you're going to see a completely white lens with no red reflex and a brown nucleus just resting at the bottom. And finally, Section 5, high-yield risk factors. Go ahead and literally screenshot this slide right now. This is your ultimate OCAP rapid-fire matrix. I want you to notice the pattern here. Diabetes, tobacco use, high myopia, and heavy alcohol consumption. They increase the risk for all three types, NSC, cortical, and PSC. Miotics and statins, on the other hand, heavily favor NSC and cortical cataracts. But the one I really want you to burn into your memory is corticosteroids, which are uniquely associated with posterior subcapsular cataracts, or PSCs. And please do not confuse this classic board scenario. Let's say you have a patient who develops a steroid-induced PSC, so you logically stop their topical steroids. Does the cataract go away? The answer is no. Steroid-induced PSCs generally do not regress upon cessation of the medication, with the one notable exception being in your pediatric patients. Also, you've got to keep your clinical guard up. If a patient's eyes are sensitive enough to develop a steroid-induced cataract, they have a very, very high propensity for steroid-induced ocular hypertension. Always, always check their pressure. So keep this entire biological framework in mind the next time you step into the clinic or sit down at the surgical microscope. A cataract isn't just a cloudy lens, right? It's a dynamic story of cellular division, mechanical compression, and osmotic breakdown. If you can visualize that continuum from the mitotically active cuboidal cells all the way to the sinking nucleus of a Morganian cataract, you won't just be memorizing the textbook. You'll understand exactly how to diagnose, manage, and teach these concepts to others. Keep studying hard, and I'll see you on the wards.